Welcome back to Real Doctors, Real Medicine. I'm Dr. Joshua Yamamoto. We're continuing an introductory series on the prevention of vascular medicine, brought to you by the Foxall Foundation. Foxall Foundation is a nonprofit dedicated to helping everyone age well. And one of the things we like to emphasize is that as we age, things naturally change. And we shouldn't view life as just a series of diseases or a bag of illnesses, but to realize that life is a series of processes that are inevitable, but because they're inevitable, that makes them largely predictable, measurable, and manageable. I'm a cardiologist in private practice, a real doctor seeing real patients. Now, a cardiologist is interested in preventing dementia in terms of vascular dementia. So, whatever happens in life, we need to have good blood flow. Every part of our body needs to have good blood flow. If we don't have good blood flow to the brain suffers. Senile, meaning age related, or vascular dementia, is kind of by definition dementia or loss of brain function from inadequate or interrupted circulation. Inadequate, we don't get enough blood to the brain, or interrupted, something blocks up that flow. That typically means clots getting up into the head. Lots of little bitty clots can cause changes to the brain, and we will eventually lose brain function. And big clots are strokes, which can cause tremendous problems to the brain. So, we've talked about the three major processes involved with the heart and circulation that will happen to all of us. Now, just because a process happens to all of us doesn't mean we all experience it the same way. This is another very key point of understanding how to manage your life, your health, to choose your priorities for your outcomes. We are all different. Everyone tends to cling to this notion that there's one right way of doing things. And when I say everyone, not just we as patients, but we as doctors, we as policymakers, we as insurance companies, this is the way. If we do a study where there's two different treatment arms, say one surgical, one medical, you can have an operation or you can have a pill, and we fail to see a difference, that doesn't mean one's worse than the other or that you should do one in preference to the other. It means we have two ways of doing something. And we could do a trial where a new therapy may not show an improvement, but it may not be any worse. The point is, we are all different and we have a lot of choices. We talked about the three processes. The first is chronic vascular inflammation, wear and tear on our arteries. Our arteries will have a natural healing mechanism, which is why we grow plaque. Always important to remember plaque is not a disease, it's a part of natural aging, and we can stop it with medication. We feed it with certain things like diabetes and smoking, but it is a natural process. Also, keep in mind that athleticism and fitness does virtually nothing to prevent vascular inflammation. The second process is a stiffening of blood vessels or a loss of compliance in our arteries. Stiffer pipes mean higher pressure. Higher pressure means more cardiac work. If at any time we inhibit our heart's function, we may have less effective blood flow to anything, particularly our brain. Our brain tends to be the most sensitive organ. And then we had an episode talking about the heart's rate and rhythm. As we get older, our heart has a harder and harder time beating reliably and regularly, and our default is to have an irregular heartbeat, meaning Mother Nature's natural compensation for not having enough heartbeats is to have sustained irregularity. And when we have sustained irregularity, we give it a name, and the name is atrial fibrillation. So I always encourage folks to think of atrial fibrillation as a description, not a disease. My heart is persistently irregular. Okay, we will call that atrial fibrillation. So perhaps the biggest theme of our last discussion was AFib is coming, don't take it personally. As a little refresher, we know that our natural pacemaker, the part of our heart that signals the heart to have a heartbeat, it gets older. We know that. Our ability to generate heartbeats diminishes with time. And if we get too slow, that encourages an irregular heartbeat. The irregular heartbeat is atrial fibrillation. About 1% of 50-year-olds will have episodes of atrial fibrillation. A full 30 to 35% of 70-year-olds and as many as half of 80-year-olds have episodes of atrial fibrillation. We know that most atrial fibrillation people don't feel. And that first, it's common that it'll come and go, meaning we will have episodes of irregularity, but we don't stay persistently irregular. So it's just a description. Do I have a heart that at times is irregular? So, yes, you have intermittent on and off atrial fibrillation, assuming we can find it. We talked about how to find it. More importantly, we emphasize that very small amounts of atrial fibrillation start to increase our risk of brain injury. When our heart is irregular, it doesn't allow for smooth blood flow that allows for blood to clot. And if the blood clots and leaves the heart, it goes to the brain, or it can go to the brain, and we start to pick off parts of our brain from all these little blood clots, and that causes chronic brain injury. And we basically know that chronic brain injury is not good for the brain, hence our desire to prevent vascular dementia. We also know that if we don't get enough blood to the brain, if our heart is too slow or too erratic, that we don't have reliable blood flow, the brain will suffer. All of our organs suffers if we don't get enough blood flow. You can transplant a kidney, but you can't transplant a brain. No matter what, we want to have best possible blood flow. So AFib is coming. Don't take it personally. It's really part of a natural aging process, which means it's something to be managed. So I just wanted to spend a few moments on how do we manage atrial fibrillation. First of all, you find it, fine. Refer to our last episode on how to find AFib, but basically you get an EKG at some point, electrocardiogram, little stickers on your chest or some form of monitor, a wearable or a microchip monitor under your skin that will find the atrial fibrillation. So you found it. We have a tendency to call everything a disease, and a disease must be cured. You're not going to cure AFib. You're not going to cure aging. You manage it. Once you find it, there are three clinical questions that we need to address. Keep in mind that different doctors have a different point of view, and there are primary care doctors, internal medicine doctors who are looking at your whole picture, and that's the most important doctor. There are cardiologists, general cardiologists like myself, who try to look at the whole heart in context of the whole person. And we also have some specialists that are more like surgeons, meaning we ask them to do specific procedures. So if you're ever talking with a doctor, it's important to understand the perspective of your doctor. So your internist, your primary doctor, and if you have a general cardiologist, our goal should be give you best possible blood flow. Again, this is a talk starting with the premise of I do not want to have a damaged brain. I need to have reliable blood flow to the brain. To have reliable blood flow to the brain, I need to have adequate circulation from the heart. And we know that atrial fibrillation is extraordinarily common once we get over 70. So you find the AFib, we ask three clinical questions. Number one, do you have a healthy heart? This is a two-way street. If you have a beat-up heart for any reason, you're more likely to have AFib. I have medical students, and when I train them, I say, look, thou shalt never say the word heart disease without an adjective in front of it. Heart disease isn't one thing. There are many different ways to beat up a heart. We have to understand what is the process or the mechanism. In the 21st century, heart disease is more commonly related to pressure and rhythm than it is to blocked arteries. 100 years ago, heart disease was rheumatic fever. A kid with a strep throat who didn't get penicillin would have an infection that would affect the heart, and it chews up the valves inside the heart, and people's heart would fail because they had bad valves, because they had rheumatic heart disease. That doesn't really happen much anymore because we have antibiotics. So then heart disease became coronary artery disease or arterial disease or atherosclerotic disease. All those are synonyms. Plaque in the arteries because the heart has to pump blood to itself. And if you have plaque in those arteries, you may not get good enough blood flow. If you block it up abruptly, that's a heart attack, and you can damage the heart. We are extremely good at preventing atherosclerotic coronary artery disease. We are extremely good at preventing heart attacks. Of course, we can treat a heart attack if it happens, but if a heart attack happens, oh, really, that may be our fault as doctors because we know how to prevent it. And it's not just about, oh, eat right and exercise. That's helpful, but vascular aging is something that we understand and can stop if we're willing to take a medication. Take a statin, don't grow plaque. Start early, don't have any plaque. Never have a heart attack. But again, talking about atrial fibrillation, The first question is, do you have a healthy heart? An irregular heartbeat isn't going to give you blocked arteries, but if you have blocked arteries and you beat up the heart, you're more likely to have an irregular heartbeat. And if you have an irregular heartbeat with blocked arteries, the heart may not be able to handle the irregularities so much. So it's important to understand the health of your heart. Two-way street. A beat up heart, you're more likely to have AFib. And if you have AFib and don't know it or don't pay attention to it or neglect it, or assume that it's always the same over time, the irregularity can beat up your heart. That's important. For folks who find out they have AFib, a lot of people don't feel it. And remember the important adage that, especially with the heart, symptoms do not correlate with risk. You can feel fine for years, but have a heart that's so irregular, racing, stuttering, that you can actually strain the heart and the heart can begin to fail. It doesn't have to. Not everybody with AFib will have heart failure. Remember, heart failure is not a single thing. Heart failure is any reason our heart doesn't meet our needs. So people always say, oh, yeah, grandpa died of heart failure. Really? Well, did he have rheumatic heart disease? Did he have coronary artery disease? Did he have untreated hypertensive or high blood pressure disease? Or did he have completely ignored atrial fibrillation and he wore his heart down? So heart disease can lead to a failing heart and heart failure, and atrial fibrillation can get you there, but it normally doesn't. I love to say people don't die of AFib unless we really ignore it, but you can have a lot of brain damage. We'll get back to that. So once we find AFib, question one, do you have a healthy heart? If you have a healthy heart, you can tolerate a lot of AFib. You may not know it at all. I've people who have hearts that race relentlessly and they never feel it, but we have to manage that so we don't let it wear down. Question two, tell me about your symptoms. Most people don't feel AFib, which is a mixed blessing because it still can make a heart unhealthy and it can still cause brain damage. That's question three. We'll get there. But you can have symptoms. Managing symptoms is desirable, but not sufficient. We have to keep the heart healthy. And you can have all sorts of symptoms and be perfectly what I call healthy, meaning you can have a strong heart that perfectly adequately circulates blood, but because it's irregular and it stutters and races, there are some people who just feel miserable. Oh, I don't like how I feel. I get that. If I was sitting here and my heart started racing 3 times its normal speed, that can be uncomfortable. But you'd be amazed, most people don't feel that at all. If you're having symptoms from atrial fibrillation, that's a mixed blessing because at least it brings it to the attention of your doctors because they have to protect you from heart failure and brain damage. Also, if you're having symptoms, it's important to realize you're not having symptoms just because you have AFib. Huh? AFib we describe as irregularly irregular. It does all sorts of things. Some folks feel the heart when it races. Actually, a lot of people don't because the racing heart is just like you're running, and you may not feel abnormal at all from a racing heart. A lot of folks will have symptoms when the heart is episodically too slow. Being too slow is actually generally much worse than being too fast, as long as you have a healthy heart. I mean, if you have blocked arteries and your heart's racing, that's a problem, but you got to deal with the blocked arteries. But you have to really work with your doctor to understand why you have symptoms. And I'm going to emphasize repetitively that slowness is more of a problem because you don't have good or any blood flow. Tell me that organs of your body are going to be happy if you don't have blood flow. And what's actually often the case is that the irregularity of it, beat, beat, no beat, 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 no beat, beat, pause, beep, beep. If you're really irregular, that can be remarkably uncomfortable. And I mention that because there's a lot of ways to approach symptom management. That's an entire discussion, and it really helps us to understand what's driving your symptoms. And that's relatively straightforward. If you look at how a heart works, you can see how somebody responds to exercise. I watch everybody walk on a treadmill, not because I'm doing a stress test, but because I need to see what you're experiencing when you're moving. You'd be amazed at how rarely doctors bother to do that. People will tell you, I get tired or breathless when I walk. And my question is always, well, did anybody watch you walk to see what happens? So you just see what happens. And this is something better done by your cardiologist or at least somebody who knows what they're looking at when they watch you walk. Is your heart racing too fast? Is it too irregular? Or more common and problematically, is your heart failing to pick up speed? And are you too slow? You cannot augment your heart rate. And that can give you a lot of symptoms. The point is, different issues have different approaches for symptoms. But I said finding AFib means we ask three questions. Number one, what's the health of your heart? Number two, what are your symptoms? And number three, what are we doing to prevent a stroke? Or to rephrase that, what are we doing to protect your brain? Now, you need to have a healthy heart to get blood up to your head, so that's part of brain protection. But basically, question three is about stroke prevention. And I'll emphasize again, prevent is an active verb. You have to do something. You have to make choices to prevent a stroke. A stroke is a blood clot to the head. And when you have atrial fibrillation, the heart is not beating regularly. And again, that discourages smooth blood flow. And there are some nooks and crannies in the heart where blood likes to pool. If blood pools long enough, it will clot, and a clot leaving the heart will go to the brain. It takes very little atrial fibrillation before that risk begins to rise. Remember, if you have AFib today, you're not going to have a stroke this moment. The stroke may come weeks or months later because it takes times for clots to begin, for clots to get bigger, and for clots to mobilize and land in your head. Also, the irregularity interrupting regular blood flow to the brain can encourage microclots forming within the brain. But either way, ask the question, what am I doing to prevent a stroke? Or what are we doing to prevent a stroke? We being you and your doctor. So you need to put this in the affirmative action question. What is my stroke prevention strategy? We are preventing strokes to prevent brain injury. We're preventing brain injury to preserve the function of our brain. In other words, I would say this is an exercise in the prevention of vascular dementia, preventing strokes. So what is my stroke prevention strategy? Cardiologists are largely trained to agonize over your risk of a stroke, and there are several things that will say that you're at a higher risk. And essentially, any risk demands the question, what am I doing to prevent a stroke? Your degree of risk may inform the answer. If you're older, if you've had a prior stroke, if you have diabetes, if you have crummy arteries, plaque buildup like a prior heart attack or arterial disease, women clot more efficiently than men do. So these are all the factors that we would consider. I don't agonize too much about all those things. I'll let my doctor do that if they want to, but the real question is always going to be, what do I do to prevent a stroke? Because it is rare that somebody has absolutely no risk factors of anything, and we would feel comfortable doing nothing. So remember that. If you have AFib and you're not doing something to prevent a stroke, that has to be an active choice, not a default. The default is to do something. What is my stroke prevention plan? Now, mostly it's pretty simple. Take a pill. Take a pill. We have a variety of pills that help discourage undue clotting. Take a pill, prevent a stroke. Yeah, it's kind of that simple. Now, there are other things that we can do because not everybody can take a pill. We get that. Now, before we get into all the pills that one can take, as you might imagine, these pills discourage clotting. That means they discourage clotting. And if you discourage clotting, it's easier to bleed. Fine. Wind the clock back 10,000 years or 100,000 years. When we were, wandering around caves chasing woolly mammoths, we didn't clot to death, we bled to death. And so we have biologically selected out to be very good at clotting. There are 24 different genes that are associated with better clotting. That makes sense because we have to not bleed unnecessarily. But in the 21st century, that's not why we die. We don't die when we bleed. We die when we clot. And this is the problem with stroke prevention, is that historically, we tend to focus way too much on the concern about bleeding. Nobody wants to bleed, but guess what? That's not why we die, and that's not why we have vascular brain injuries. It's not why we have dementia. It's not from bleeding, it's from clotting. We die when we clot. You clot the brain, that's a stroke. You clot the heart, that's a heart attack. You clot other organs, lung clots, pulmonary emboli. Clotting is mostly how we die. It is not common to die from bleeding. A friend of mine is a gastroenterologist, a stomach specialist, and he loves to quote people or quote him. He'll tell folks, look, we have blood banks. We don't have brain banks. In other words, if someone has a bleeding ulcer, yeah, that can be quite dramatic. But if you look up the leading causes of death, you're not going to see ulcer among them. People don't hemorrhage to death. We can treat that. No, I don't want people to bleed, but I really don't want them to clot. As a digression, I think a lot of our fear of bleeding is hardwired into our DNA. Again, going back hundreds of thousands of years. I also think World War II made a big impact because people got shot on the battlefield, and probably millions of American GIs came home and they had all experienced somebody who had bled to death, maybe in front of them. I get that. And then all their kids, welcome to the baby boomers. You're now in your 70s, going on into your 80s with this ingrained concern about bleeding, which is fair, but you have to realize that's not going to be your undoing. Our undoing is going to be clotting. And so I would love to shift the conversation away from, oh, I don't want to bleed to, oh, I don't want to have vascular dementia. Oh, I don't want to have a stroke. So the medicines to prevent strokes are commonly called blood thinners. Now, I've mentioned that I studied physics in college, so it always bugs me to call this a blood thinner. It has nothing to do with thickness or thinness or viscosity. Our blood flows for other reasons. These are medicines that prevent undue clotting. So I love to call them stroke prevention medications. What's your stroke prevention medication? If somebody has a stroke, quietly in the back of my mind, I'm always thinking, how did we allow that to happen? They had a blood clot to the head. Now, if you're taking a stroke prevention medication and still have a blood clot, at least we were trying. But if you have a stroke and you've got a blood clot to your head, we ask, well, what stroke prevention medication were you on? And if you were on nothing, then that's awfully unfortunate because it's hard to get that clot to go away once it's landed in the brain. We talk about treating strokes. The best way to treat it far and away is to prevent it. Prevent it. So take a stroke prevention medication. The biggest reason we have strokes is because we have plaque in our arteries going up to and into our brain because we allow that to grow. We can stop plaque. Yes, you have to take a statin. Go back and watch the first episode or listen. We can stop plaque growth, and because nobody feels plaque growth, and we're under the misconception that somehow exercise prevents vascular inflammation. It doesn't. Exercise is good for cardiac fitness. That's wonderful. Exercise and take your statin. And the other reason we have strokes is because we have atrial fibrillation and we don't feel it. And we think that our lack of symptoms somehow makes us exempt from the fact that we have episodically irregular heartbeats and we haven't taken a stroke prevention medication. So think about and discuss with your doctor your stroke prevention medication. Currently, there's a set of pills. They're typically called direct oral anticoagulants or DOACs. In early 2026, they're supposed to be generic. They've been around for over a decade. They got really expensive. They hopefully will get cheap again. It's a pill. Take it. It's not really that complicated. The two most common ones used in the United States are apixaban, commonly named Eliquis, and rivaroxaban, known as Xarelto. There's a third one, a little bit older, called dabigatran or dabigatran, named Pradaxa, which is rarely used in this country because it gives everybody heartburn. And there's another one called adoxaban or Savesa, which is almost never used in this country because if you have two healthy kidneys, it washes out and it's less effective. But one of them, they all work. I don't really have a burning preference as to which. Rivaroxaban has the advantage of being a once daily medication. Apixaban has the advantage of being a twice daily medication. Whichever one works for you. Twice daily medication means you don't have quite as many highs and lows, but it's easier to miss pills. Once daily medication is easier to take, but you also have to make sure it's dosed properly. Apixaban, for example, as twice daily, is notoriously underdosed. So it's a phenomenal medication, but take it in a useful dose. So that's your stroke prevention medication. Now, there's a lot of studies that look at prevention of strokes taking these medications. Guess what? They're all good. If you have AFib, by and large, you should be on one of them unless there's a reason not to. But the default is to be on a stroke prevention medication. And if you look at people and compare those who have had strokes versus those who didn't, to no great surprise, the people who didn't have a stroke have better brain function. In other words, they have better cognitive function. They think better. So if you don't damage the brain, you're not going to have brain damage. What? Isn't that obvious? The point being, if you don't want to have vascular dementia, prevent strokes. That's a related concept. The prevention of vascular dementia means preventing strokes. So people are more afraid of bleeding than clotting because you can't see the clot. People think strokes are just tragic and random things. They are tragic, but they are not random. They happen for reasons. Doctors are often reluctant to risk any harm. Makes sense. Hippocratic oath. First, do no harm. If I give you a pill and you have a bad nosebleed, yeah, that's on me. And I feel bad about that. But if I don't give you a pill and you have a stroke, you know what? I'll probably never know. Think about that. If you're working with an internist or a cardiologist and you make the decision to not take a stroke prevention medication and you go on to have a stroke, no one is ever going to tell your cardiologist. Funny thing that they tell you meet a neurologist and you're like, oh, that's really bad. You've had a stroke. Your brain doesn't work. Maybe you can't speak or you can't walk or you can't eat or what have you. And they say, look, you have plaque in your arteries and you need to ask your doctor to look for AFib. And somebody looks for AFib and you're like, oh, I already knew I had AFib. And we're like, really? You'd be surprised how often that happens. But I wasn't taking a stroke prevention medication because I didn't want to be on a quote blood thinner, end quote. But now you have brain damage. No one's actually going to tell your cardiologist that happened. We never hear about that. We'll hear about the bleeding. Oh, your patient with AFib is here and they have a nosebleed. Don't get me wrong. I have somebody in the ER every year with nosebleeds because if your nose bleeds from behind the bony part, you can't pinch it. So you got to go to the ER. And it's dramatic. I get that, but it didn't leave you with permanent brain damage. So we hear about the bleeds, and everyone is adverse from taking the risk of causing the quote harm of a bleed. So when you are discussing, hopefully you have a chance for discussion with your doctor or your cardiologist, how to prevent strokes. Yes, you have to confront the risks versus the benefits, but you have to ask the risks of what? Not all bleeding is bad. Say that again. Not all bleeding is bad. It's hard to come up with a good stroke. So, yeah, I always err on the side of saying my bias is I don't like brain damage and I don't want my patients to have brain damage. So, I always think of best possible stroke prevention and work backwards from there. What do I mean by not all bleeding is bad? All right, so there was a terrific study that came out in the fall of 2019. So nobody heard about it because the pandemic came around. It was called the Compass trial. You can look that up. It took about 27,000 people. It was a big study who had vascular disease, plaque in their arteries, prior heart attack, prior stroke, prior cardiac stent, or they just had plaque buildup, but less or 50% of plaque in their arteries. So nothing that in their carotid arteries going to their brain. And they're totally asymptomatic. And they randomized them to get standard care, which is basically an aspirin so you don't clot off, or dual therapy with very low dose rivaroxaban, which I'll point out is available generically, really low dose. The trial had to be stopped early. Why? There was overwhelming efficacy. There was a 44% reduction in stroke rates, fewer heart attacks, fewer deaths. So that was wonderful, but nobody ever heard about it. Hey, this is one of the most phenomenal stroke prevention studies. No one heard about it because the company really couldn't market it during the pandemic, and then they decided not to. But it doesn't mean rivaroxaban plus aspirin isn't a phenomenal stroke prevention strategy. But in that trial of 27,000 people, there were over 1,000 new diagnoses of cancer. Huh? What the heck does that have to do with anything? When you gave people adequate stroke prevention, the combination in this case of rivaroxaban and aspirin, low dose, mind you, you have to dose these things properly. I won't get into dosing. You can work with your doctor on that. But it had a tendency to make cancers bleed. So if you have a precancerous colon polyp, you suddenly could have blood in your stool, or very commonly, we saw blood in urine. Bladder cancers, kidney cancers, and the tubes that connect your bladder and kidney and all that, when you give them stroke prevention medications, they often bleed. So I love telling people these medicines, call them blood thinners if you must, they don't make people bleed, they just make bleeding more enthusiastic. So, in fact, if you were a 70-year-old person taking one of these medications and you had blood in your urine, there is almost an 18% chance that you actually had a cancer that we unmasked early. Huh. Not all bleeding is bad. Now, in the clinical trial, be like, oh, that was a bleeding complication. Really? You had blood in your urine, or you became mildly anemic because you were trickling blood from your colon cancer that you didn't know you had. So, a couple of points with this. One, when you read about studies and they talk about increased bleeding, you kind of have to ask, well, bleeding what? Did I just get a little anemic? And did I get anemic because I had a colon cancer I didn't know about or a bladder cancer I didn't know about? So is that really bad? It just means I got to treat my cancer early. And believe me, treating cancer early is a good thing. Think in general that if I'm worried about bleeding, what am I really casting that against? Am I casting that against my fear of brain damage? Do I want to have a stroke? Do I want to have a clot up into the head? Which is worse for me, having permanent brain injury or a nosebleed? There's a lot recently about, oh, aspirin's good, bad, and but you have to realize when the biostatisticians say that your likelihood of harm is equal with or without aspirin, harm of what? Harm of a bleed or harm of a brain injury? So I get it. If you really don't want to have a bleed, I accept that. It's not my personal choice, but I'm kind of a medical libertarian. If you're not prepared to accept a risk of bleeding, my job is simply to point out the benefits that you may be foregoing. Because I don't want you to not have a chance to make that choice. It's another thing about medicine in general. We're not all the same. There's not one right answer. And I get it that different people react differently to medications. We're not all the exact person in a clinical trial, but you need to understand what your choices are. And the one thing we have a hard time doing in medicine, in real medicine, when real doctors practice real medicine, our toughest commodity is time. And it can take a while to explain these choices, which, to be honest, is why we're trying to put these out on a broadcast so that people can understand what choices they're being confronted with. So you can go to your doctor and say, okay, I found that I had plaque in my arteries. What am I doing to keep the plaque clear? And what am I doing to prevent a stroke? I found my AFib. What am I doing to prevent a stroke? Sometimes you don't need to do anything. That's true. Sometimes you can just take an aspirin, and that may be quite sufficient. Often, if you have atrial fibrillation, you're best served by taking a pill that requires a prescription, which soon will be cheap. In ancient times, like the 1950s and 60s, we gave people rat poison, commonly called warfarin. If you're still on warfarin, you really need to go see a doctor because it's kind of well below standard of care, and you're hard pressed to find a good reason to be on warfarin when we have novel agents that are much better and much safer. There are a couple of exceptions. You can work on that with your doctor, but they're rare. So am I on a stroke prevention medication? Now, circling back to the management of atrial fibrillation. Question one, do I have a healthy heart? Question two, am I managing symptoms? Question three, what am I doing to prevent a stroke? There are people who have things that relentlessly bleed that we cannot really stop, and that's a lifetime risk. So we can consider other things than a pill to prevent clotting. And for that, there's kind of a really cool procedure. It's called the occlusion of your left atrial appendage, commonly known as a Watchman. There are other manufacturers, but most people refer to it as a Watchman. It is a relatively invasive procedure, and if we actually showed people the tools we use, I don't think anybody would sign up for it. However, it's an outstanding tool for people who really can't take the appropriately dosed anticoagulation or the things to prevent clotting. Basically, we stick an IV in the vein in your leg or your groin. It's a huge catheter. You'll be asleep, and we slide this thing up into your heart, and there's that corner of the heart where clots like to form, and we stick a cork in it so that clots can't form there. That's a gross oversimplification. Suffice to say, if your doctor recommends it, go talk to the people who do them. There are guys out there just itching to do this procedure because cardiology has turned into a procedural field where we don't like to think about our patients or talk to our patients so much as do things for them, with them, or to them. So this is one of those procedures that in the right person is outstanding because then you don't have to be on medications. I have a delightful patient who has permanent atrial fibrillation, doesn't feel it. He's got a pacemaker, which we'll get to, and he feels marvelous, but he is just way too active in this world and keeps getting thrown off his horse and thrown from tractors. And he's 85, living life to its fullest, and he keeps hitting his head on things. So it's like, all right, we're going to give you a Watchman. That's great. So we can plug that up. If you take a Watchman, you only need aspirin therapy to prevent strokes. You don't need to take anything else. So there are still more things about how to keep a heart working well, how to ensure adequate blood flow to the brain. But I wanted to talk a little bit on the approach to atrial fibrillation. Find it. AFib is coming. Don't take it personally. Once you find it, it doesn't matter whether it's comes and goes, what we call paroxysmal, whether it sticks with you, persistent, or whether it's you're stuck with it for life. We call it permanent. I mean, it does matter, but the next questions are going to be, how do I know I have a healthy heart, and what am I doing to keep my heart healthy? Number one, keep your heart healthy. Number two, if I'm having symptoms, do I understand why? Is it because I'm too slow or too fast or too irregular? Trying to, quote, cure the AFib is not the issue. We haven't talked about ablations. Maybe we'll do that next, but you don't cure AFib so much as you manage it. And then, as this opening series is about preventing brain damage, ask your doctor, what are we doing to prevent a stroke? Should I take a pill? Should I have a procedure? Or is it okay to do nothing? If I'm doing nothing, what are really the risks involved with that? So, the Foxall Foundation, dedicated to helping everyone age well. I'm a real doctor practicing real medicine. I see thousands of patients. I'm a cardiovascular doctor. I like to say I do prevention. What am I preventing? Premature death, heart failure, and brain damage. Preventing strokes, preventing vascular dementia. So always remember, prevent is an active verb, so work with your doctor to keep your brain healthy. So I'm Josh Yamamoto, a real doctor practicing real medicine. Thank you for your time.